Hello, my name is Junyoung Kim, an assistant professor at the Department of Exercise Science at Syracuse University. First of all, I would like to thank the IOHSK for giving me an opportunity to share my research entitled Lifestyle Intervention on Biomarkers of Type 2 Diabetes in Obese Youth. Today, I'm going to share a series of my research, which is focusing on youth-onset type 2 diabetes by introducing key pathophysiological risk factors and use other contrasts in terms of disease progression. Afterward, I'm going to introduce two emerging novel biomarkers of type 2 diabetes risk in obese youth with the purpose of early identification of youth at high risk. At the end, I'm going to introduce several lifestyle interventions that have been conducted for these two emerging biomarkers. Before I introduce my research, let's take a look at this figure showing the trends in adult and childhood obesity. As you can see, both prevalence of obesity has been continuously increased. Now 20%, approximately 20% of the kids are being obese. And if we consider the overweight, then the prevalence of overweight and obese are jumping up to 50%. This obesity epidemic public health concerns also leads more concern, showing this ever escalating rate of type 2 diabetes in youth. Type 2 diabetes previously has been introduced and considered as an adult chronic disease, but now, as shown in this figure, for the certain minority, which include the non-Hispanic Black and Hispanic, shows a gradual increase in the incidence of type 2 diabetes with annual increase of 7.1%. So why this is happening to the pediatric populations as we consider type 2 diabetes as a other disease? We should understand this pathophysiological risk factor for type 2 diabetes. So let me introduce the key pathophysiological risk factor, the most powerful predictor of type 2 diabetes in the future is the beta cell function relative to insulin sensitivity, in other words, disposition index. So let's take a look at this figure. There are two pathophysiological risk factors here, insulin sensitivity on x-axis, insulin secretion on the y-axis. Insulin sensitivity indicates insulin action, so efficiency. Insulin secretion indicates the amount of the insulin secreted by pancreas. When you look at the normal kids with the normal glucose tolerance, they don't have any certain burdens, meaning they can manage, so continue, show the persistent homeostasis with a well balance between the insulin sensitivity and insulin secretion. However, let's say if those kids become obese or overweight, then they don't still are normal with the normal glucose tolerance test, but their location will be moving up and toward the left, as we can see in number 2 on this hyperbolic curve, showing that these obese kids will have a reduced insulin sensitivity. In other words, have insulin resistance, and their beta cell function, insulin secretion, will be increased. Why? In order to compensate this given insulin resistance. That's good. Compensatory beta cell response is good thing. However, over time, then pancreatic beta cell will be exhausted, now developing a new hyperbolic curve, which is representing the impaired glucose tolerance. In other words, pre-diabetes. And of course, as expected, more over time, then type 2 diabetes will happen. So this hyperbolic curve and disposition index apply to both adult and youth population. However, recent clinical trial observations continuously show that youth-onset type 2 diabetes appears to be worse than other type 2 diabetes. This observation has been well shown in this figure. And today, treatment option for adolescents and youth diabetes studies, the clinical multi-center clinical studies, represent the youth population, and the other green colors show the adult multi-center clinical trial. When we look at the failure rate, so treatment failure rate in response to the metformin, which is the most popular drug for treating type 2 diabetes, now we can see the more than 50-60% of the youth with type 2 diabetes fail to manage their blood glucose level, while only 20-30% of adults with type 2 diabetes fail to maintain their glycemic control by metformin. This is a similar case to the different combined therapy, which is the combination of the metformin and low Z-glucose. Moreover, when you look at the changes in beta cells function, which is the powerful predictor of diabetes, then we can see that youth with type 2 diabetes have faster and a higher degree of the minus, so deterioration of the beta cell functions compared to the adult population. This attests our statement that youth onset type 2 diabetes, the disease progression seems to be worse, severe than the other onset type 2 diabetes. So far, we don't know why this is happening. In order to investigate this mechanism, I, with my postdoc mentor, Silva Arsenaian, collaborated with the other endocrinology, Dr. Toledo, to compare the in vivo insulin sensitivity in obese youth with IGT versus obese adults with IGT, the IGT being considered a virgin state of type 2 diabetes. We did not include the type 2 diabetic population here in order to eliminate any confounding effects on the outcome measure, which include the different treatment modalities, different period of the diagnosis. In these studies, we performed a pair-matched analysis with respect to BMI, sex, and race, with the 34 obese IGT youths with 17 obese IGT adults. Measurements include the 2-hour oral glucose tolerance test and body composition by DEXA, and 3-hour hyperinsulinic euglycemic clamp combined with stable isotope. At this point, I want to highlight that the clamp is the gold standard measure of insulin sensitivity and beta cell function. In this case, we measure the hepatic and peripheral insulin sensitivity. So when you look at the physical characteristic between youth versus adult, as expected, there are large difference in the age. However, based upon our vigorous pair match process, we do not see any difference in the BMI, total body fat mass, percent body fat, and fat-free mass, indicating that those two different age groups are equally obese. However, when we look at the clamp data, insulin sensitivity, then now we can see that youth with IGT compared with adults with IGT have severe insulin resistance, attested by 53% reduction in the hepatic insulin sensitivity and 42% reduction in peripheral insulin sensitivity. After the publications, we further analyzed the adipose tissues insulin resistance, which is novel indicator of insulin resistance. The results are the same. We can observe that adults compared with youth have better adipose insulin resistance. In other words, adipose tissue insulin resistance is also severe, 50%, 50% in youth with IGT compared with adult with IGT. Our study potentially explained the earlier onset of type 2 diabetes in youth through an early and amplified burden on a beta cell destined to decompensate. However, we need to explain why youth are more insulin resistant than adults despite similar adiposity. After our studies, the most biggest clinical trial in youth-onset type 2 diabetes in the USA, the RISE Restoring Insulin Secretion Study, performed and published two publications attesting that the youth compared with adults have a twofold severe insulin resistance than equally obese adults. By now, then we can ask, what can we do for preventing youth-onset type 2 diabetes? Because onset type 2 diabetes progress fast, youth onset type 2 diabetes contains more aggressive pathophysiological risk factors. So my answer to this question is that only detection of obese youth who are at highest risk for type 2 diabetes with metabolic abnormalities, so that we can prevent any aggressive symptoms before they develop type 2 diabetes. And in order to do this, we need to identify a novel biomarker. So let's move on to our main interest. So this publication at Diabetes Care in 2012, actually written by myself when I was a PhD student, and I was very interested in the glucose response curve as I was involved in the oral glucose tolerance test in the obese Latino youth. When I participated in this project, this is what I thought in the normal physiology. Whenever participants came to our clinic after 10 to 12-hour fasting, then their fasting glucose level will be normal. And after they ingest the glucose solution, then of course blood glucose level should be increased. And at some time, at certain time point, then we would expect the glucose concentration will be decreased again, right? So this seems to be normal. However, there is an additional one more phenotype, which is called the biphasic, and this is characterized by the second increase in glucose concentration. So you can observe the early peak at 30 or 60 minutes, subsequent to some certain decrease in their glucose concentration, and we increase here. And more interestingly, when we compare the insulin sensitivity and secretion, we observe that obese Latino youth with biphasic response have better insulin sensitivity level and have better beta cell function, thereby lowering the risk of type 2 diabetes when compared to another kids who have monophasic group. And more importantly, this finding has been independent of fasting and 2-hour glucose concentration, which is traditional risk factor. In fact, American Diabetes Association suggests taking a fasting and 2-hour glucose concentration to diagnose type 2 diabetes. But as you can see here, these two different phenotypes, mono and biphasic group, have the same fasting and 2-hour glucose concentration. After my first publication in the glucose response curve, but there was still a research gap. No study exists verifying its utility against the gold standard measure of insulin sensitivity and beta cell function. And little is known about the physiological mechanisms responsible for the shape of this OGTT glucose response curve. So after I moved to the Children's Hospital of Pittsburgh, pursuing my postdoc training under the Silver Australian, I conducted the study to verify its utility against the clamp measure insulin sensitivity and beta cell function. Again, this is the gold standard measure of pathophysiological risk factor for type 2 diabetes. And also, I aim to examine if there are any differences in incretin, pancreatic hormone responses, and free fatty acid concentration to see if what hormone response are responsive for these two different phenotypes, mono versus biphasic. In this study, a total of 277 non-diabetic obese adolescents who complete the OGTT were included. All participants complete the body composition by DEXA and abdominal adipose tissue by CT and or MRI, and HbA1c and adiponectin data were collected. And importantly, 2-hour OGTT was performed to measure glucose, insulin, FFA, glucagon, GLP-1, GIP, and pancreatic polypeptide hormone response. And this is our highlight. Out of the total cohort, 106 participants are further selected randomly and in the random order. They actually additionally underwent the 2 different clamps, hyperinsulinic euglycemic clamp, which is the gold standard measure of hepatic and peripheral insulin sensitivity, and they underwent the hyperglycemic clamp, which is also another gold standard measure of insulin secretion, so beta cell function. So out of the total 106 participants complete both clamps. When we take a look at the results, and these 2 groups have similar physical characteristics. However, one highlight from this table is adiponectin, which is the indirect indicator of insulin sensitivity. You can see that obese youth with biphasic have higher adiponectin concentration compared with monophasic, indicating that the monophasic response is representative of insulin resistance. When we more comprehensively look at the hormone response during the 2-hour glucose tolerance test, in line with the previous finding, there is the same fasting and 2-hour glucose concentration, but area under the curve of this curve, which is indicating of the glucose metabolism, was blunted in the monophasic compared to the biphasic. When we look at the insulin dynamic, this is the same case. Insulin control was worse in the monophasic versus biphasic group. And lipid metabolism, represented by the free fatty acid concentration, is also higher in the monophasic. So metabolism was worse in the monophasic group compared with biphasic group. All of those hormone response further support our highlight, showing that the monophasic group have 20% lower hepatic insulin sensitivity and peripheral insulin sensitivity. More importantly, there was no compensatory increase in first and second phase insulin secretion in this monophasic group. And without this compensatory secretion, now we can see the statistical difference in the disposition index, showing the kids with the monophasic response have significantly lower disposition index. And this hyperbolic curve in the monophasic group move toward the left toward the origin. And this shift to the origin is the most powerful predictor for future development of type 2 diabetes. So by now, we test this utility of OGTT drive in this glucose response curve. Now I'm curious, then how this is maintained or persist or change over time. So that's why I work with the Today group. This Today, treatment option for adolescent diabetes. We actually collaborate with this group to investigate whether the OGTT glucose response curve at randomization, so the baseline, could predict glycemic failure rates over 18 months follow-up period among obese youth with type 2 diabetes. Again, I want to highlight that the previous studies did not include the diabetic patients. Now we include type 2 diabetic kids so that there is one more glucose response curve phenotype exists in CSN increase, which should be a worst phenotype. Briefly, a total of 662 obese youth with Recently diagnosed type 2 diabetes are included, and our patients are treated by metformin alone, or metformin plus glucosidone, or metformin plus lifestyle intervention. So we follow up them over 48 months, and the major outcome was glycemic failure rate, indicated by the persistence of the HbA1c level greater than equal to 8%. And another outcome measure was changes in insulin sensitivity and better cell function. So here's the baseline characteristic. So there was no dramatic differences among those three phenotypes, mono, bi, and incessant increase, except the pubertal stage. But this is the most interesting part, the longitudinal analysis of failure rate among those three phenotypes at baseline. So this indicates the survival curve and the log rank test result for the freedom of glycemic failure. So we are calculating this area under the curve for each phenotype, which was classified at the baseline, and see how many participants in each group are failed in terms of their glycemic control. And as we can see here, almost 60% of the kids with type 2 diabetes who have incessant increase, so gradual increase in glucose concentration during the OGTT at baseline, are failed to control their glycemic status. However, you can see only 40% of the kids who show the biphasic at baseline fail their treatment options. So that we can conclude these different three curve phenotype can predict the different failure rates. After this, I also want to introduce one another emerging biomarker, which is 1-hour glucose concentration. By now, we can think of the ADA suggestion, which is focusing on the fasting and 2-hour glucose concentration, may not enough, in terms of identifying the individual who are at higher risk for type 2 diabetes in the future. Therefore, I was very interested in the middle time point, so that we can better reflect the pathophysiological progress of type 2 diabetes. So I worked with my mentor, Michael Goran at USC, to examine its utility of 1-hour glucose concentration greater than or equal to 155 milligram per deciliter during an OGTT to prospectively, so longitudinally, identify obese Latino youth at risk for type 2 diabetes. So let's see some previous literature why this 155 milligram per deciliter was suggested from the other study. So Abdul Ghani, the San Antonio research team in the adult population, first introduced this 1-hour glucose concept by conducting the ROC curve analysis. So comparing the predictive power of each individual glucose concentration in terms of the development of future type 2 diabetes. And as you can see here, the predictive power of 60 minutes of glucose concentration was powerful than the others. And further, based on the sensitivity and specificity, the best cutoff point was introduced at 155 milligram per deciliter. So this longitudinal study in adult was tested by my postdoc teams at Children's Hospital of Pittsburgh, showing that 1-hour glucose concentration above 155 milligram per deciliter is significantly associated with lower beta cell function in youth, which is further independent of their glycemic status. However, at the time, there was no long-term studies in pediatric. For this reason, I collaborate with the USC Solar Diabetes Project, which was main PI is Michael Goran. And we collaborate together to examine the 236 overweight and obese Latino youth with family history of type 2 diabetes. In this project, we have 8 years follow-up data with a mean follow-up of 4 years. And our participants underwent the body composition screening by DEXA and 2-hour OGTT and measured the insulin sensitivity and secretion by intravenous glucose tolerance test, which is another gold standard measure of pathophysiological risk factor for type 2 diabetes. So based upon their oral glucose tolerance data, we classify two groups, above versus below, based on the 1 hour glucose concentration of 155 milligram per deciliter. We are performed the long-term analysis by using the linear mixed modeling and generalized estimating equation modeling. For the baseline characteristic, as we can see here, there are some differences, but more importantly, we can easily find that the kids in the above 155 milligram per deciliter compared with the below group have lower AIR, so lower acute insulin response and lower disposition index here compared with these two groups. This means that the people who have 1 hour glucose concentration greater than or equal to 155 milligram per deciliter will have a worse beta cell function, worse insulin secretion. So this is the same result with my previous finding, cross-sectional finding. So let's move on to the new finding, a novel finding, which is the prospective analysis. So the x-axis indicate the visit number, indicating the years, and y-axis indicating the disposition index. As I mentioned before, disposition index is the most powerful metabolic predictor for future type 2 diabetes. And we can see that the kids who have more than 155 milligram per deciliter of the 1 hour glucose concentration gradually decrease in this disposition index, while below 155 group have re-increase at the end. This translates to the 55 reduction in the DI in above group and 29% increase in DI in the below 155 group. We don't specifically know about this mechanism or potential reason. We assume that all of our participants underwent the tuber development during these 3 to 6 visit number years. So this baseline 155 above versus below can predict whether the kids can recover their puber impact on this beta cell function, which can be recovered in the below group, but above group cannot recover. Additionally, I limited our data set to the normal glucose tolerance group only in order to see if this 1 hour glucose above and below can predict the future development of hyperglycemia. In this case, I called hyperglycemia because I combined pre-diabetes and type 2 diabetes together in terms of increasing the sample size. And interestingly, we can see that the kids who have more than 155 milligram per deciliter at 1 hour glucose concentration at baseline are 2.5 more likely to develop hyperglycemia compared with those kids with 155 below. In order to pursue additional investigation on this single time point of the glucose concentration, I have further examined the predictive power of each individual glycemic indicator to identify progression to prediabetes or type 2 diabetes over time. Inconsistent with the previous other literatures, I found that the predictive power represented by the ROC curve area under curve was 73%, the greatest and higher in the 1 hour glucose concentration than the other individual biomarkers, which include the fasting glucose and HbA1c. And interestingly, if we make a full model which combine all of those individual biomarkers, then predictive power was 77%, but only predictive power of the 1-hour glucose concentration showed no statistical difference between these two. In conclusion, our series of the previous data showed that OGTT glucose response curve in 1-hour glucose herald the type 2 diabetes risk, which cannot be captured by classical traditional biomarkers, including the HbA1c, fasting, and 2-hour glucose concentration. So it would be essential to understand the potential impact of intervention and prevention on those emerging type 2 diabetes risk markers. With this scientific curiosity, I, with my doctoral mentor, Gabe Shaby, wrote a review paper to see any recent evidence on impact of exercise on disease risk factor among obese youth. In this review paper, I specifically compare the traditional versus non-traditional risk factor for type 2 diabetes and CVD. And we can see that in response to a single bout of aerobic exercise, the improvement of 1-hour glucose concentration was significant and greater when compared to the other time point. This greater improvement on the 1-hour glucose concentration compared with the others indicates that 1-hour glucose concentration can be our potential target of any therapeutic or intervention study for treating or preventing type 2 diabetes. In line with this, my PhD students, Gerard Rosenberg, also performed a pilot study, which is called the effect of a 12-week lifetime intervention on novel biomarker for type 2 diabetes in obese Latino youths. In fact, this has been published at our IOHSK. So we use the pilot data from the Every Little Step Count DPP program with the collaboration of my doctoral mentor, Gabe Shaby, to examine the effect of this lifetime intervention on emerging biomarker, which include the glucose response curve and 1-hour glucose concentration among high-risk obese Latino youth. We have two groups, lifetime intervention group versus control group. And as you can see here, lifetime interventions are quite comprehensive, including the 3 exercise sessions per week and 1-hour weekly education sessions. And we consistently measure the body composition, lipids, and oral glucose tolerance tests before and after this 12 weeks lifetime intervention period. And also, I want to highlight that as we are focusing on the pediatric population, the weight reduction was not our purpose and aim, as kids are growing continuously. And even after our 12-week lifetime intervention, there was no significant reduction in the weight, but we can see their better body composition and look at the waist circumference or BMI percentile. And those following tables are the changes in the fitness, activity, and nutrition exhibiting all the better improvement after the 12-week intervention. So let's move on to our original interest, which is the changes in glucose response curve. When you look at the changes in the glucose response curve before and after the intervention in the control group, then you can see there is no actual shift or difference in terms of the prevalence of mono and biphasic. However, when you look at the intervention group, now you can see that the prevalence of monophasic, which is unhealthy phenotype, is dropped from the 88% to the 63% after the 12-week intervention. That's the case as well when you look at the biphasic, of course. And for the ease of interpretation, I also want to share this table and showing that 4 of the participants in the intervention group show any shift from the monophasic to the biphasic group, while none of them show the opposite, from the mono to the biphasic group. So let's see whether this is the same case for the 1-hour glucose concentration. In the control group, we did not observe any significant difference. But in the intervention group, the prevalence of below 155 has been increased. The prevalence of above 155, which is worse phenotype, has been decreased after the 12-week intervention. Again, this indicates the 5 of them in the intervention group show the shift from the above 155 to the below 155, showing the improvement, and none of them show the opposite case. So now I agree the 1-hour glucose concentration and glucose response curve can be improved after the lifetime intervention in non-diabetic kids. So now let's go back to the today clinical trial, see if whether this curve can be changed after our 3 different treatment modality, metformin alone, metformin and lozi versus metformin plus lifestyle. Again, please be advised that our population in this today concentration is obese youth with type 2 diabetes. So when we look at the changes in this pattern, unfortunately, we did not observe any significant findings, no clear trends in the shift of any phenotype, incessant, mono, and biphasic. And this is all the same case for each treatment modality here. In conclusion, exercise and lifestyle interventions that aim to reduce type 2 diabetes reflect by OGTT glucose response curve and 1-hour glucose concentration in obese children and adults are needed. And in response to intervention trial, we found the 2 different cases. In obese youth without type 2 diabetes, the OGTT response curve and 1-hour glucose seem to be shifted from the unhealthy to healthy phenotype. But unfortunately, in obese youth with type 2 diabetes, the emerging risk biomarker seems not to be improved. This also indicates some youth versus adults contrast, or also indicate how aggressively we should prevent the type 2 diabetes development in this obese adolescent population. I would like to thank all of my collaborators, Syracuse University, and all my mentors and colleagues in Children's Hospital of Pittsburgh, Arizona State University, and University of Southern California. Thank you everyone for listening my presentation, and I hope you enjoy our IOHSK conference. Thank you very much.